guys, this chapter is going to cover aerobic exercise. This is chapter 7 in your book. We are skipping around a little bit, but we're getting back to this one now. And so we are going to start going over and talking about, let me get this up here, the principles of aerobic exercise. So we're going to talk a little bit about fitness, which is just the ability to do physical work. There's a lot of things that go into determining a person's fitness level. We can look at their strength, their endurance, their cardiorespiratory function. Flexibility actually plays a little bit of role in this as well, as does body composition. With that being said too, don't just look at someone and think that you can automatically determine their fitness level. Fitness levels can range anywhere from poor to superior, and we often will base these on an energy expenditure, and levels are oftentimes clinically measured by looking at VO2 max, which is the maximum oxygen consumption that a person uses. So that's a scientific way to look at fitness levels. Typically, with most of our patients that we see in the clinic, we're not going to be assessing VO2 max levels, but we'll talk about some of the other ways that we can sort of assess their fitness levels. So this would be how to truly scientifically measure VO2 max. This is VO2 max testing. So if we have any exercise physiology majors, kinesiology majors, some of you guys may have actually done some of this exercise testing as part of your undergrad. But this is just looking at the body's capability to use oxygen efficiently. So it's looking at the maximum amount of oxygen that's consumed per minute when the individual has reached their maximum effort, and it's then expressed relative to their body weight. So in milliliters per kilogram per minute of activity. And so this is kind of like that exercise stress testing. So they usually have the person biking, treadmill, something like that to take them to that maximum effort, to where the point where the patient or person says they're done. Endurance is a measure of fitness, and that's the ability to do some type of physical work for an extended period of time. This is usually, I think, what we sort of automatically start to think about when we think about fitness. We think about those people who can do lots of long-term work, right, or long-term physical activity. So we can look at it as either muscular endurance, which is going to be repeated contractions by an isolated muscle group, which is typically considered an anaerobic type activity. Or again, what I think we usually think about whenever you hear the word endurance is more of like cardiovascular endurance, where we're using large muscle groups doing dynamic exercise for long periods of time. So things like swimming, biking, walking, running, these are our aerobic type activities where we are consuming more oxygen and using large muscle groups. Doing aerobic training or conditioning, we typically do that to improve the energy capacity of the muscles. It is dependent on the intensity, duration, and frequency of the program. So again, taking a walk versus going out for a run, those are different types of intensity. Durations, obviously endurance activities, we typically add longer durations to that. We build fitness levels by increasing our time. And then frequency of the program is, again, how often we're participating in that. Again, improved aerobic conditioning is typically seen as improved endurance. We usually equate those two together. Again, training is going to be based on the specificity principle, and we've talked about this before, that SAID principle, specificity of training. So the patient's going to improve in the task in which they are performing. So, for example, you want to get a swimmer better at swimming, they need to swim more. So again, not necessarily their ability to run. I can absolutely attest to that. I'm definitely more of a runner. My kid was taking swim lessons. I thought, oh, that'll be so great. I can get some exercise in while they're taking their swim lessons. Took my suit, some goggles, got in, started swimming some laps. I think I made it about 2 laps and I was about done because that's very, very different activity. So again, your body adapts to what you train it in the way in which you train it. So there we go, adaptation. Again, this is the ability of the muscles and the cardiovascular system to change over time in response to a training stimulus. And we can see pretty significant changes within a 10 to 12 week period. So adaptation is going to increase the efficiency of the cardiovascular system, increase muscular efficiency, and increase performance. This is dependent on the ability of the organism to change, right? So the person has to actually do these things, and they have to be in a position where they can actually start to see some of these changes. Maybe they have a disease process or something like that going on where you're not going to be able to see some of these changes. And we also have to be able to meet the training stimulus threshold. So that means you have to continue to challenge. We talked about this before also. But again, you can't just do the same thing over and over and over again, because your body will start to adapt to that. So you have to continually challenge your body, challenge the patient if you expect to see gains, right? We talked about doing like active range of motion of your biceps. If it's a healthy bicep, you're going to have to do more than that. You're going to have to challenge it if you expect to see strength gains. So myocardial oxygen consumption. It's the amount of oxygen consumed by the heart, and that's determined by, or the need for oxygen is determined by your heart rate, blood pressure, your myocardial contractility and afterload, which is ventricular force that is needed to open the aortic valves at the beginning of systole. And the oxygen received at the heart depends on arterial oxygen content, hemoglobin dissociation, and coronary blood flow. The heart is getting its blood supply from the coronary arteries. You have 4 coronary arteries that are basically supplying the entire heart muscle with its blood supply. Coronary blood flow is going to be affected or can be affected by blood pressure, coronary artery resistance, and collateral circulation as well. So we'll talk about, as we're working with populations who may have compromises here, and how we can sort of monitor them through exercise. When you are at rest, the heart is going to extract about 70 to 75% of the oxygen from the circulating blood. When demand increases, myocardial ischemia can occur. When you start to exercise, the increased oxygen that the heart needs to keep up with that comes from an increase in blood flow through the coronary arteries. So as you start to exercise, the heart is going to demand more oxygen to keep up with that. The coronary arteries are going to start to supply the heart with more blood in order to keep up with that. Here where it talks about myocardial ischemia, that's one thing that can happen. So you see people who, in this picture, they go out and they shovel snow and they keel over from a heart attack. What happens is someone who's not used to that type of physical demand all of a sudden puts a stress on the heart, and the heart can't keep up with it. Sort of side note, little story, my dad's a relatively active older person, and he was bicycling on a trail with some friends. And his one friend, who was a little bit older than him, I'm going to say he was in his early to mid 70s at the time, noticed, he wasn't having any trouble on the bike rides, wasn't having any trouble keeping up with anybody, except when he was pedaling uphill, he would notice like a pain or sort of tightness in his chest. Downhill was fine, level ground was fine. It was just every time he pedaled uphill. So it's concerning enough. He did go see his doctor, and here they found out that he actually had some blockages in his coronary arteries, and it was exertional angina or chest pain on doing the pedaling uphill part, where he didn't have to exert himself quite so much on the downhill or the level ground. And so that was actually his trigger and the sign that he had some heart blockages, and so he had some stents placed, and he's doing fine now. So deconditioning, if you're ever out in the clinic, you're absolutely going to hear the term. You're going to see some patients. If you're in hospitals and nursing homes, you're definitely going to get some people that are coming in with the diagnosis of deconditioning or being deconditioned. So this usually occurs with prolonged bed rest or just inactivity in general. And it's oftentimes seen with patients after they've had an acute illness or they have long-term chronic conditions. Perhaps laziness, sedentary lifestyle, right? That's usually what we call it. But this is usually, you start to see a decline in a lot of their systems. And again, it's usually because of some sudden illness or a chronic illness where they're just not able to be very active, where they're sitting around most of the time or even bedridden for periods of time. So we'll see pretty quick changes in their VO2 max. Cardiac output and muscular strength is going to be affected as well. So some of the effects that we see with prolonged bed rest are going to be a decrease in muscle mass. Muscles start to atrophy relatively quickly, right? Usually within like 48 hours is about all it takes for that to start. So because of that, we see some loss of strength. We start to see a decrease in cardiovascular function. There's actually a decrease in the total blood volume that is circulating. The body recognizes that there's just not that much movement, not much activity, and it actually does not circulate as much blood as it did previously. There's also a decrease in plasma volume then because of that. Heart volume decreases, orthostatic tolerance decreases, so that means that your patient is more likely to experience orthostatic hypotension upon moving, especially from like supine to sitting, sitting to standing. A decrease in exercise tolerance, and also a decrease in bone mineral density. And again, these things can happen relatively quickly. So, let's say your patient develops pneumonia, they have a 2 or 3 day hospital stay, they can come out of that pretty much deconditioned. Okay, so it doesn't take very long. All right, so talking about some energy systems. This is going to be a brief review because I know you guys have had this stuff before, but this is looking at the metabolic systems that we have that produce ATP, carbon dioxide, and water. So 3 major systems that depend on the intensity and the length or duration of the activity in which we're participating in as to which one is going to be supplying us with the energy. So there's the phosphagen or ATP-PC system, there's the anaerobic glycolytic system, and then there's the aerobic system. So your ATP or PC system, this phosphocreatine and ATP are stored within muscle cells. This does not require oxygen. So again, this is anaerobic, and this provides energy for short, quick bursts of activity, typically the first 30 seconds of intense exercise. So this is using a chemical fuel source, no oxygen is required, really quick bouts of activity, and then you're done. So we're going to rely on ATP and PC for this. If we go slightly longer, usually about 30 to 90 seconds of exercise or intense activity, we sort of switch over into the anaerobic glycolytic system. So glucose is now going to be the fuel source for energy. Again, no oxygen is required yet. And so moderate intensity, still somewhat short duration, again, 30 to 90 seconds worth of activity. Once we cross that threshold, 90 seconds to 2 minutes of activity, and we then get into the aerobic system. So again, we saw sprinters, long distance runners, right? And this is typically what we equate to this, the short bursts of activity versus more of the long haul type of activity. So glycogen, fats, proteins are going to be the fuel source in the aerobic system. Oxygen is absolutely required. And again, this is going to be the predominant system after that second minute of exercise. So any activity lasting longer than that, we're going to be calling in on the aerobic system. So again, with a lot of our patients, even if we're not doing an extensive aerobic program with them, we do often have our patients warm up on the bike or the elliptical or the treadmill or things like that. And after that first 2 minutes of activity, we are going to be relying on their aerobic system and their cardiovascular reserves to keep them going, even for something as simple as a warm-up. So looking at the recruitment of motor units, again, just a review, type 1 are our slow twitch fibers. They have a lot of myoglobin and mitochondria, high oxidative capacity, low anaerobic capacity, and these are more of your endurance type fibers, right? So they're supplied by small neurons, low threshold of activation, used for more your low intensity exercises, more like your postural maintenance type muscles, low endurance, long-term kind of things. As compared to your type 2B or your fast twitch fibers, these have faster contractile responses, low myoglobin, low mitochondria, high glycolytic capacity. Again, activities requiring more power. They have more anaerobic capabilities or activity. There are a type 2A fibers that have characteristics of both type 1 and type 2B fibers that do a little bit of both. So they're kind of a little hybrid between the two. So they have both anaerobic and aerobic activities. So let's talk about some of the responses to exercise, the physiologic response to exercise. As far as the cardiovascular system, there is what's called the exercise pressor response. So it's a sympathetic response, which includes vasoconstriction in the non-exercising muscles increased myocardial contractility, so the heart has to pump faster to pump blood out to all those exercising muscles. You'll see an increase in heart rate and an increase in systolic blood pressure. So again, this is going to redistribute the cardiac output, sending it more to the muscles that are working. So how much of this happens depends on the amount of muscles that are being involved in the activity and the intensity of the activity. With this, there can also be something called visceral shunt, and that means that blood flow is going to be reduced to the viscera, or the internal organs, and sent to the exercising muscles. So this is why eating before exercise isn't always the best thing, right? Why you should wait 30 minutes after you eat before you go swimming, because typically you eat, blood is sent to your stomach and your intestines to start the digestion process. If you go and start doing intense exercise, that blood needs to be shunted to those working muscles, less to do with digestion, and then you can end up with stomach aches and cramps and just overall not feeling well. So again, peripherally, blood is going to be shunted from the non-working muscles to the working muscles. So say you're running. Again, the blood is going to be shunted more towards the leg muscles because they're the ones that are powering through. Those are the ones that are being used for long periods of time, less to, say, like your upper extremities, because you're not using them as much. We will indeed see an increase in cardiac output, again, because the muscles are demanding more oxygen. The heart itself is demanding more oxygen. It's going to pump harder and pump faster to get the blood circulating to all of these muscles. So we'll see an increase in stroke volume, increase in heart rate, an increase in blood flow, again, to those working muscles. So again, as we exercise, we start to monitor heart rate. That is something that's pretty easy for us to monitor while someone is exercising. And we do expect to see an increase in that, again, because the heart is having to do more work. We do expect the systolic blood pressure to increase as well when someone exercises, and we'll get into some specifics in just a little bit. The respiratory response to exercise, we're going to see an increase in the gas exchange within the first 2 breaths of performing heavy exercise. There will be an overall increase in the tidal volume and an increase in the respiratory rate, right? You start to breathe faster, harder when you start to exercise. There's also going to be an increase in alveolar ventilation, which is going to increase the available oxygen and get rid of the carbon dioxide a little bit faster. So again, keeping up with that gas exchange. Because of that increase in blood flow, we do expect increased oxygen to the working muscles, and then we're going to extract that oxygen and use it because hemoglobin is going to carry the oxygen to the area. It will be released, we'll see a resultant increase in carbon dioxide, which causes more oxygen to be released. So it sort of keeps the cycle going. And we'll also see an increase in red blood cells to the area because, again, we're increasing blood flow to these working muscles. So normal responses, heart rate should increase as workload increases. Stroke volume is the amount of blood that's coming from the left ventricle. It should also increase as work increases. And cardiac output is your heart rate times your stroke volume, which should also, again, increase with aerobic activity. Looking at the arterial-venous oxygen difference, this is going to help to show us how much oxygen is being extracted by the tissues. Again, as the intensity of the activity increases, your tissues should begin to extract more oxygen from the blood. So typically at rest, 15 to 20% of the circulating oxygen is going to go to the muscles. Remember, most of it's going to stay towards the viscera, your internal organs, just to kind of keep homeostasis there. But at exercise, when exercising, up to 80% of the oxygen in the circulating blood can go to those muscles. So normal blood pressure responses to exercise, the systolic pressure should increase with the workload, sort of in conjunction with that. And then the diastolic shouldn't change a lot, right? We expect the systolic to rise. A change less than 15 millimeters of mercury is normal for the diastolic pressure. If it's dropping or going higher or changing more than 15 millimeters of mercury, that is an abnormal response to exercise. Keep in mind too that both Systolic and diastolic blood pressure are going to be higher when you're doing upper extremity aerobic activity as compared to lower extremity, just due to the proximity of the muscles to the heart. So the arm bike, right? If you have someone going on the arm bike, if you've never tried one, when you get out in the clinic, try one. They will get your heart rate up really fast, right? So doing upper extremity aerobic activity will cause your blood pressure to go up a little bit higher. Pulmonary ventilation, the respiratory system is going to increase your respiratory rate, your depth of breathing, in order to increase the amount of air exchanged for every minute of exercise. Your tidal volume, which is the amount of oxygen that's moved in and out during normal respiration, is going to increase, right? So you're going to breathe usually a little bit deeper, increase that tidal volume when you're exercising, and your respiratory rate, how often you breathe, is going to increase as well. Just a side note here, and we have charts later on that go over all this stuff, but in trained individuals, we do expect that their respiratory rate and their heart rate at rest are actually going to be lower than people who are not trained, right? So people who regularly participate in aerobic activity tend to have lower respiratory rates and heart rates than people who don't regularly participate in those activities. All right, so let's talk about some abnormal responses to exercise. So if the heart rate doesn't rise in proportion to the intensity of the exercise, so you're doing a pretty intense exercise and the heart rate maybe raises a little bit, but not very much, that's a little bit alarming. If the systolic blood pressure does not rise in accordance with the activity, if there's a decrease in the systolic pressure greater than 20 millimeters of mercury, because remember, a normal response is that the systolic blood pressure should rise. So if it decreases, again, that's an abnormal response. An increase in the diastolic pressure, more than 15 millimeters of mercury. Again, we don't expect to see a big change in that number, in the bottom number. If the person ever experiences any chest pain, left arm pain, jaw pain, shortness of breath, or abnormal diaphoresis, sweating, or dizziness, those are all abnormal responses to exercise. So health-related benefits of regular exercise, I'm sure you guys have all heard these things before. This isn't any new news for you, but they can help to decrease fatigue, enhance immune function, improve your body composition, just basically give you a better sense of well-being, decrease the risk of a lot of diseases, including coronary artery disease, some different types of cancer, high blood pressure, diabetes, osteoporosis, anxiety, and depression, and also help to improve your blood lipid profile or your cholesterol numbers. So how to design an aerobic program. So we need to think about our goals for our patient and what are we hoping to get out of this program. The American College of Sports Medicine recommends the FIT method for determining exercise parameters, which is frequency, intensity, time, and type of exercise. So frequency is how often the exercise should be performed, which is going to be dependent on a person's health and their age. Typically, a lower intensity program needs to be performed more often, right? So we talk about, like, when we think about endurance and strengthening, strength was usually higher weights for lower reps, endurance was lighter weights over longer periods of time. Same kind of thing here. So if you're doing a lower intensity program, you're going to have to do that more often to see effects. For cardiovascular improvement, we do typically recommend 3 to 4 times a week participating in some type of an endurance-based activity. And research has shown that 30 to 45 minutes of aerobic activity 3 times a week or more decreases the risk of coronary artery disease. So intensity is how much exercise a person should perform or how hard they should work, which again needs to be enough to overload the system beyond its typical capabilities. And then once the person adapts to that much exercise, then we need to start to increase the intensity. So again, I think I've probably used this example before when we talked about like physical conditioning and things like that. But if I made us all go outside and run a mile, some of you might be fine, some of you might be gasping for air by the end, and that's fine. But if we continue to go out and run a mile every single day, we're all eventually going to get to the point where we're like, you know what, that's not so bad. I think I could do that. we start to adapt to it, right? So then in order to continue to challenge, we're going to have to either start to run that mile faster. So we're going to have to increase the intensity that way, or we're going to have to start running longer distances and longer times and increase endurance that way. So again, we're looking at the training stimulus threshold. So that point in which we're actually going to get a conditioning response, which again, there's multiple things that go into this: age, health, gender, previous activity level. But again, based on the overload and the specificity principle that we've talked about previously, we need to overload the system if we expect to see any changes. And however we choose to train it, that's where the person's going to start to adapt and see those changes based on specificity. All right, so getting into intensity 2, this is where we can start to look at like training zones and heart rate zones and things like that. So usually somewhere between 60 and 90% of a person's max heart rate will help to create a conditioning response, again, dependent on their age, their fitness level. The easiest way to figure out a person's max heart rate is to just take 220 minus their age. And so get that number, and then you can choose, say, we want to work at 70% of their max heart rate, and then that will give you an idea of where their heart rate should be while you're exercising. There is another method, it's Carvonen's method, that determines, or that you can use to determine heart rate, and it's based on heart rate reserve. So it does take a little bit more into account. Here's the whole formula to figure that out. Carvonen's method is almost always going to be higher than if you just did 220 minus the age. So again, depending on which method you use, and again, sometimes just for the sake of simplicity, we're just going to use max heart rate as 220 minus the age, and then figure out where the person falls in there. If someone has an underlying disease or some sort of chronic disease process going on, wherever they start to experience any symptoms, whatever their heart rate is at that point, that's used as their max heart rate, right? We don't want them to exercise to the point that they start experiencing symptoms. So if we've noted that and we can identify where that heart rate is, we want to try to keep them below that. That's their max heart rate. We're going to exercise below that when they're working out. If you do high intensity activity for short periods of time, you'll see a greater increase in VO2 max than doing moderate exercise for longer periods of time. This is one of the principles behind like HIIT exercises, which are pretty popular right now, that high intensity interval training type exercise. So we're doing sort of short bursts of high intensity exercise, and then you take a little bit of a break, and then you get back and you alternate through that way. Higher training intensities and long exercise intervals have a faster training effect. And again, VO2 max is going to be the best measure of intensity, but VO2 max and heart rate are literally linearly related. So again, if we don't have the capabilities or the time to figure out what VO2 max is for all of our patients, heart rate is a pretty good gauge of where they are. So time, how long do we have someone exercise? It's going to be dependent on the total work that's done. So again, the intensity, the frequency, and also the person's fitness level. If you increase the intensity level, you should probably decrease the duration or the time. And if you decrease the intensity, again, we typically need to do them for longer periods of time. 20 to 30 minutes of aerobic activity at 70% of the person's max heart rate has been shown to be optimal as far as developing cardiovascular fitness, reducing disease risks, all those types of things. If you are working below that, if your heart rate is below 70% of their max heart rate, then we should increase the time. So up to say maybe like 45 minutes. If the patient is deconditioned, right? And like I said, your person following a short illness or with a chronic illness, 3 to 5 minutes of high intensity workouts can be enough, right? So that's a very short bout of activity. And when I say high intensity workout, with these patients, it's probably not going to take a lot to get their heart rate up to those maximum levels. And then we get into, what kind of exercise should our patient be doing? So again, it should meet the individual's needs. It should also meet their capabilities, right? We shouldn't be asking them to exercise or do things that are just not going to pertain to them at all. The aerobic program should involve large muscle groups being used for a longer period of time. And as I mentioned, detraining can occur in as early as 2 weeks, right? So take a week or two off of your normal training program and it's going to be pretty difficult to get back into it. So again, to imagine being sick or being in the hospital for a week or two or even longer, you're going to see some pretty serious effects after that. So components of a good aerobic program are going to include a warm-up, the aerobic exercise period, and then a cool down at the end. The warm-up, again, here it says 10 minutes. Sometimes we're lucky if a whole program lasts that long. But again, just to sort of warm the person up a little bit, to gradually warm up the muscles and core body temperature, which again, the idea is that will reduce the risk of injury by not just jumping right into the regular exercise. During the warm-up, we should try to get the heart rate up to within about 20 beats of where we're aiming for. And then during the warm-up, we expect to see an increase in the muscular temperature, an increase in oxygen extraction by the muscles, an increase in circulation to the muscles, and an increase in venous return. Again, trying to reduce the risk of injury by doing a warm-up. During the actual exercise period, again, the intensity needs to be enough to increase the stroke volume, cardiac output, to actually challenge the cardiovascular system. The activity has to be within the patient's tolerance, and it has to be above the threshold level for adaptation. So again, this is where we talk about like exercise progressions and things like that. And when you're working with a patient in the clinic, we don't want them to just be doing the same exercises day in, day out with the same reps, the same weights, nothing ever changes. The person will adapt to that and they need to be stressed or challenged in order to get continued improvement. So we need to see progressions. We also need to keep the exercises below the level that would cause any negative symptoms. So if exercising at this level causes them to have, say, increased sweating and dizziness, then we don't want to exercise to that level. So the activity should be submaximal, right? We are typically not asking our patients to go all out as hard as they possibly can. Rhythmical, repetitive, dynamic, using large muscle groups. That is pretty much the definition of aerobic activity. So a couple of methods of training, you've probably heard of some of these. We have continuous training, which is a submaximal type of exercise. It's aerobic, so we're going to use slow muscles, usually somewhere in the ballpark of 20 to 60 minutes long for an exercise bout. Work rate, again, will increase progressively as training improvements are achieved, so we'll continue to progress. Overload is often accomplished by increasing the duration, so by adding more time onto the exercise. And this is a pretty effective way to improve endurance in individuals who are already healthy. Interval training, again, this is a popular training protocol right now. This is work followed by rest period, which can be either active or passive. The duration of the rest period varies, again, depending on, again, fitness level, prior activity levels, goals of the program, and type of training that you're doing. But the rest is designed to allow ATP stores to replenish because, again, remember, these are usually pretty short bouts of exercise. So I've seen somewhere it's like 30 seconds on, 10 seconds off, 45 seconds on, 15 seconds off. So in general, the amount of work that's completed is greater than that of continuous training because you're doing more of these sort of bursts of high intense activity. Circuit training is using a series of exercises. You can do static and dynamic, large muscle groups, smaller muscle groups. The idea is that we're going to stress both the cardiovascular system and the muscular system at the same time. And then this kind of goes into circuit interval training, which is using sort of circuits and intervals together. So we're using aerobic and anaerobic capabilities here. Some examples of this would be doing like a circuit type training, maybe doing like an upper extremity strengthening exercise intensely for, 45 seconds, taking 15 seconds off, then doing a lower extremity targeted exercise. all out, 45 seconds, taking 15 seconds off, then maybe doing like a core exercise, taking a break, doing an aerobic activity, and then just continually sort of cycling through that way. So we're addressing different muscle groups, and you're getting a total body workout by the end, and you're stressing the cardiovascular system because you're quickly moving from one station to the next. Then at the end of the exercise period, we should have a cool down phase. So again, it's not just doing this intense exercise and then all of a sudden just stopping, because we don't want blood to start to pool in the extremities, or we don't want a sudden drop in the blood pressure as everything sort of starts to return to normal. So again, it's just sort of a more gradual phase back into, lowering gradually the heart rate and the respiratory rate and everything to get them back to normal. So cardiovascular changes that result from training. So someone who trains, someone who exercises, someone who is considered to be fit, right? At rest, they should have a decreased resting heart rate. Their blood pressure should be lower, especially their systolic pressure, and they should have increased blood volume and hemoglobin counts. With exercise, we should see their heart rates increase. Some may actually decrease. They can actually exercise more efficiently. So you might not see a big spike in their heart rate when they start to exercise. We do expect to see an increase in stroke volume and cardiac output, in the extraction of oxygen to the muscles. We expect to see an increased VO2 max, an increase in work capacity, and a decrease in myocardial oxygen consumption because the heart starts to get more efficient. It doesn't need as much oxygen to work as hard. So respiratory changes with training, again, at rest, trained individuals, fit individuals should have increased lung volume and increased diffusion capacity. With exercise, that continues. Also, we'll see a decrease in the air ventilated with the same oxygen consumption. So they get more efficient at that as well. They don't have to breathe as heavy or as hard during exercise because their body has become more efficient at extracting the oxygen. Metabolic changes with training. Again, at rest, trained individuals should have more muscle hypertrophy, more toned muscles, an increase in their capillary density, increase in number and size of mitochondria, and an increase in myoglobin. With exercise, we'll see a decreased depletion of muscle glycogen, decrease in blood lactate levels. So we shouldn't have that buildup of lactate in the blood, lactic acid, which leads to soreness in the muscles. Decreased reliance on the ATP-PC system for energy expenditure, more reliance on the aerobic system, and the increased ability to oxidize carbohydrates or to use carbohydrates. Other changes resulting from aerobic training are an overall decrease in body fat, decrease in cholesterol, an increase in heat acclimatization, and an increased strength of bones, ligaments, and tendons. So as you can see, lots and lots of benefits to exercise. So some of this, again, is just educating your patients why it's so important for them to participate in regular aerobic activity. So you guys will see there is an aerobic assignment, an aerobic activity for you guys to participate in. So please make sure you do that. Have some fun while you're at it too. Thanks.